Chapter 13 is mandibular anesthesia. In this chapter, we're going to be discussing the importance of the anatomy of the mandibular nerve, and then the different branches of the mandibular nerve and its association with local anesthesia. We're going to talk about the comparison with the mandibular nerve to the maxillary nerve blocks. And then we're going to talk about the various types of nerve blocks in the mandibular arch. So one of those nerve blocks is going to be the inferior alveolar block, and one of them is going to be the buccal block that we're going to go over. And then along with the inferior alveolar block and the buccal block, we're going to talk about several others as well, such as the mental block, the incisive block. We'll briefly talk about the Gao-Gates mandibular block, the Vazirani-Akinosi, and yeah. Alright, so we know that the mandibular nerve of the fifth cranial or trigeminal nerve and its branches can be anesthetized in a number of ways, and that helps us numb certain parts of the mouth at a time whenever we're working on quadrants for SRP or in highly sensitive patients in any kind of procedure. The supraperiosteal injection of the mandible is not as clinically effective as the maxilla, and there's going to be substantial variation that exists in the anatomy of local anesthetic landmarks of the mandible and the associated nerves. And so, as we kind of discussed in chapter 12, the mandible can be harder to anesthetize because not only does it have more dense bone, but there's a lot of variation in the anatomy and the landmarks from patient to patient. And so that's something to keep in mind with mandibular anesthesia. So this is figure 13-1 in your book. It shows the local anesthetic nerve blocks and the related structures that are anesthetized with those nerve blocks. All of the maxillofacial injections have been associated with the visual analog scale ranging from 0 to 5. I really like these pictures or these depictions because it shows you exactly, it's color-coded version and shows you exactly what is anesthetized with each injection, which is really nice study material for you guys. This is really good to memorize. You want to memorize all of these. You should know with each injection exactly which structures they are anesthetizing. Whenever you do become a dental hygienist and get your license, you want to know what injections you have to give your patient depending on what area you'll be working on. Not only do you need to know for that, but prior to that you need to know these for future exams and then your board exam as well. So these are the different blocks. We already mentioned all of them. Keep in mind with this that patient pain management and hemostatic control depends on the extent of the procedure that's anticipated for that patient, and then it also depends on the structures needing to be anesthetized. These are the traits that are unique to the mandible. So we talked about how the mandible is more dense than the maxilla, making the supraperiosteal injections of the mandible not as successful. Supraperiosteal injections are more effective on the mandible of the anterior teeth and can be successfully administered for crossover innervations, and then substantial variation in the anatomy and landmarks of the mandibular bone. That's going to complicate mandibular anesthesia, as we had talked about before. These are all facts that are important to remember when deciding to administer mandibular anesthesia. The first block that we're going to go into is the inferior alveolar block. This is going to be recommended for anesthesia of the mandibular teeth, their associated periodontium, and the lingual soft tissue to the midline, plus the facial soft tissue anterior to the mandibular first molar. Anterior to the mandibular first molar. That's important to remember. The inferior alveolar nerve block is not a true mandibular block. The Gauge nerve block is the true mandibular block. However, the IA nerve block is the most commonly used injection in dentistry. So this is a dissection of the right infratemporal fossa at the injection site or needle insertion point for the inferior alveolar block. And then there it's labeled for you. So 1 up here, 1 is going to be the maxillary nerve, 2 is the posterior superior alveolar nerve, 3 is going to be the posterior superior alveolar artery. Then we go into, let me see, 4 right here. 4 is going to be the long buccal nerve, okay. 5 right here, that's going to be the medial pterygoid muscle. 6 right here, that's going to be the lingual nerve. 7, this is an important one right here, this is the inferior alveolar nerve. So to kind of rewind a little bit, 7, that's going to be the injection, that's the nerve that you're trying to reach, the inferior alveolar nerve that you're anesthetizing with the IA block. And then 4 right here, that's the long buccal nerve. That's another injection that we're going to learn about today. And then several other ones that I'm not mentioning right now, several other nerves and arteries and muscles that I'm not mentioning right now, but just wanted to mention the most important ones. 18 is the mandibular nerve. Yeah. So speaking of the IA block further, this figure, it's going to show the distribution of the IA block as well as the VA block. And it's also giving you an intraoral view of the distribution of the IA block as well as the VA block. On the right, it's showing a facial view of the extraoral distribution of the IA block as well as the VA block. So the area that is anesthetized for the IA nerve block, it's going to be all of the mandibular teeth to the midline. So if you're doing one quadrant, all of those mandibular teeth up to the midline on that quadrant are going to be numbed from the IA block, which is why it's one of the most commonly used, or the most commonly used injections in dentistry, because it numbs that whole quad for you, with exception to the lingual or to the buccal tissue near the molars. And so that's going to be where we need to do the long buccal block for anesthetizing that area. The nerves anesthetized are the IA nerve, the lingual nerve, the mental nerve, and the incisive nerve. Again, anesthetizes mandibular teeth in one quadrant up to the midline, as well as the periodontium anterior to the mental foramen and the first molar, as well as the facial gingival tissue, lingual soft tissue to the midline, lower lip to the midline, anterior 2/3 of the tongue, and the floor of the mouth. This is the target area for the inferior alveolar block and the facial view of the anesthetic distribution after the block. And then here's another dissection of kind of what we're looking at. So number 4 is that lingual nerve. Number 3 is the inferior alveolar nerve. So there's that inferior alveolar nerve. Number 4 is the lingual nerve. Number 2, we have the inferior alveolar artery. Okay. Number 6 is that long buccal nerve. Here's the clinician position of the right-handed clinician for the IA block, both on right and left-hand sides. The right-handed clinician on the right side should be positioned at 8 to 9 o'clock. If there's a left-handed clinician for the right injection, they should be positioned at 4 to 3 o'clock. For the right side, sorry, that was the right side. For the left side, the right-handed clinician should be positioned at 10 o'clock, and the left-handed clinician should be positioned at 2 o'clock. And this is showing syringe stabilization with fulcrums for the IA block. The pinky finger of the dominant hand is going to be resting on the patient's chin for the right side, and the pinky finger of the dominant hand resting on the patient's chin for the left side as well, and just different positions for that. Sometimes if you have too short of fingers, a really good technique is to, especially for this side, is to make sure that your elbow is pressed against your side as tight as possible, which is going to give you more of a fulcrum, but you still want to try to find another fulcrum for stabilization with your fingers as well. This is going to be, of course, important anytime during anesthesia, so anytime you're giving injections, but especially important for you as students when you're first giving your injections. You need that fulcrum, you need that stabilization, because you guys are going to be nervous and shaking during your injections. This next picture here is a photograph with a cotton tip applicator of exactly where the target area for the IA block. So the landmarks are going to be the anterior border of the ramus, the coronoid notch, the pterygomandibular fold or raphe, the pterygomandibular space, and the mandibular occlusal plane. It's important to note that, so let's say that this was your needle, the point of its insertion, the target area. You want to place your thumb, you want to rest that on the coronoid notch. And then what you do, you leave your thumb on that coronoid notch and you bring this to bisect your thumbnail, and you'll be in the right spot every time as long as your thumb is on the coronoid notch and you're bisecting your thumbnail. The barrel of the syringe is going to come over the premolars. So that's a good way of knowing that you're in the right spot too. Your finger on the coronoid notch, the needle is bisecting your thumbnail, and the barrel of the syringe is over the premolars. All right, so to explain this a little further, the correct injection site for the IA is the intersection of two imaginary lines, which is at the depth of the pterygomandibular space. So the imaginary horizontal line shows the correct height, right there, and the imaginary vertical line is going to show the correct anterior-posterior direction of the injection, okay? The deposit location of the IA block is slightly superior to the entry point of the IA nerve as it moves inferiorly to enter into the mandibular foramen. In case of anesthesia failure, we want to reattempt at a slight superior level than the first injection. And we'll learn about that a little bit more as we get further along into injections. But here is the picture of the needle insertion for the IA block. Again, at intersection of that horizontal line and the vertical line using the coronoid notch and the pterygomandibular fold. You're reaching for the middle of the pterygomandibular space at 6 to 10 millimeters superior to the occlusal plane of the mandibular molars. This is another figure of needle insertion into the pterygomandibular space for an inferior alveolar block. You want to insert the needle until gentle contact with the bone of the medial surface of the mandibular ramus, and that is going to be about 3/4 the depth of a long needle to reach the target location. Now, if you just keep going, and you never reach bone, that means you're not in the right spot. You need to reach bone about 3/4 of the way in, and that's how you know you're in the right spot for this injection. Now, the complications with the IA block, so the failure rate of the IA nerve block is about 15 to 20%. the lack of consistent success is going to happen. So it's not going to be consistent success every time with this injection. And that has to do with anatomic variations in the height of the mandibular foramen on the medial side of the ramus and the depth of the soft tissue penetration required to achieve pulpal anesthesia. Another reason of that lack of consistent success is that patients are not symmetrical in their anatomic positioning. And so everybody's going to be different. There's going to be a lot of variations. If bone is contacted too soon, then that means that the needle tip is located too far anterior on the ramus. And the correction with that is made by withdrawing the needle partially or completely and bringing the syringe more closely superior to the mandibular anterior teeth, moving anteriorly across the dental arch by 1/2 of a tooth at a time. When it is newly directed, you want to then reinsert to correct the depth. Now, if bone is not contacted, then the needle tip is located too far posterior on the ramus, and correction for that is made by withdrawing the needle partially or completely, bringing the syringe more closely superior to the mandibular molars, moving posteriorly across the dental arch by 1/2 a tooth at a time, and then you want to reinsert the correct depth. It's important to partially or completely remove the needle tip before making any syringe adjustments. Now, with the complications with the IA block, some hints. So you want to seat the patient upright or semi-upright after the injection. If there was a failure with the IA block, you can use the Gauge-Gates mandibular block. And then we talked about what happens if bone is contacted too soon or not contacted at all, which happens, and you have to adjust with the IA block. Sometimes you can't contact bone right away, and the needle is not 3/4 of the way in, and so you have to reposition, and again, we'll practice this in clinic once you guys get back. All right, so this figure shows troubleshooting of the IA block. Figure A right here, that's the intraoral view of the long needle not contacting bone. So you can see that it goes all the way to the hub, and it's more than 3/4 of the way in. It's all the way in up to the hub. And so that long needle is not contacting bone, and the correction would be to, after partially or completely withdrawing the needle, you want to move the barrel of the syringe more closely superior to the mandibular molars and reinsert. And then with this correction, the needle tip is going to be more anterior. Now, if bone is contacted too soon, then that means that the needle tip is located too far anteriorly on the ramus. So you would want to bring the syringe closely superior to the mandibular anterior teeth to move the needle tip more posteriorly. All right, this figure shows a supraperiosteal injection in the lingual tissue on the medial surface of the mandible. This is to obtain pulpal anesthesia of the mandibular first molar following a less than clinically effective inferior alveolar block. So you had complications with the IA block. It was not very clinically effective. This supraperiosteal injection can be done possibly anesthetizing the accessory innervation of the mylohyoid nerve. With this injection, if bone is not contacted, the needle tip is located too far posterior on the ramus, so you would want to bring the syringe more closely superior to mandibular molars and move the needle tip more anteriorly. Let's see. All right, some complications with the IA nerve block. So as clinicians, we need to be prepared. One of these complications is called the lingual shock. As the needle passes by the lingual nerve, as you're going to your depth and angle for the IA block, the moving needle shocks the lingual nerve. And the symptom is only momentarily and it's unavoidable. Prepare the patient for this normal occurrence so that they're not completely caught off guard. And what you can do is at that lingual nerve, Sometimes people stop at the lingual nerve and deposit some solution, but depositing small amounts of solution as the needle advances will not prevent that lingual shock. It kind of feels like an electrical shock that's sent through the tongue. It really surprises patients sometimes. Sometimes patients don't have much of a reaction to it, but you just need to be prepared for them having a reaction to it. And we also need to prepare them that it's something that they might feel so that they don't think that something is terribly wrong with the injection. Other complications with the IA nerve block would be inadequate anesthesia. So this is caused by depositing the solution inferior to the mandibular foramen. And the remedy for this would be to re-inject in a more superior injection site. So another way to remedy this is just to frequently review learned landmarks and troubleshoot to improve your technique as well. Another complication would be incomplete anesthesia. The cause of this is crossover innervation from the contralateral incisive nerve or the bifid inferior alveolar nerve. The remedy would be to administer a supraperiosteal injection on contralateral central incisor or administer contralateral incisive block for anterior teeth, or to administer IA nerve block inferior to usual anatomic landmarks for a bifid IA nerve. And so we need to make sure we learn to read dental images, radiographs carefully, noticing any deviations in normal anatomic landmarks. Radiographically, a double mandibular canal may be detected, indicating that there is a bifid inferior alveolar nerve. And therefore, that's whenever you would administer the IA nerve block inferior to the normal anatomic landmarks. You want to be prepared, so you will not know about the crossover innervation from the contralateral incisive nerve until you experience it or until the patient feels it. So you want to make sure that you document it in the chart. Okay. Another complication with the IA nerve block is incomplete mandibular first molar anesthesia. The cause is possibly due to the innervation by the mylohyoid nerve that is not anesthetized by the IA nerve block. The remedy would be using a 27 gauge long needle you want to insert at the apex of the selected tooth at 3 to 5 millimeters or 1/4 the depth of the needle. Aspirate and deposit 1/4 of the cartridge over 20 seconds. Another remedy would be using the Gauguin's mandibular block, which is the true mandibular block. Okay. Another complication would be transient facial paralysis, which is caused by the administration of anesthetic into the parotid salivary gland containing the facial nerve. The symptoms of this would be the inability to close the eyelid and the drooping of the lips on the affected side. And to prevent that, this is why it's important to always contact bone before depositing the solution. Now, this facial paralysis, it's temporary, but it can last for hours. Another complication is a hematoma. This IA nerve block has the highest positive aspiration rate, so it's important to educate patients. Let them see the bruising and give clear post-anesthetic directions if they do have a hematoma, and then you just want to make sure we reassure the patient. If the hematoma occurs in the area of the pterygomandibular space, like I said before, let them see the bruising, let them see what had happened after the treatment is finished so that they know that it's okay, it's going to go away. You saw the damage, and just reassure them that it's something that does occur sometimes with injections. The next complication is paresthesia. So the causes of this is usually trauma to the lingual nerve, also lack of adequate fascia around the lingual nerve. It could be possible neurotoxicity of the local anesthetic agent, dental infection from a contaminated needle, problematic surgical extraction of impacted molars. The symptoms of the paresthesia is going to be an abnormal sensation such as a burning or prickling, pins and needle feeling. The most usual cause is going to be the problematic surgical extraction of impacted molars. All right, the next block that we're going to discuss is the buccal block. This buccal block does not anesthetize any teeth. Instead, it anesthetizes the gingival tissue of mandibular molars. So the indications, this buccal block is usually given immediately after the IA nerve block to complete the quadrant anesthesia. Again, the nerve anesthetizes the long buccal nerve, and the structures is the buccal gingival tissue of the mandibular molars. Needle length and gauge would be 25 gauge long immediately after the IA block, so you withdraw from the IA block and immediately give a buccal block. But you can use a short 27 gauge short if the buccal block is given alone. This is a picture of what the buccal block looks like. So you're parallel with those teeth, with the molars, and you just go straight back until you hit bone right here. You're only going in a couple of millimeters into the tissue, but this is the target area and distribution. This outline shows the distribution of the buccal block. So gingival tissue of this area, with including the molars. This is the operator position, which is going to be the same for the IA nerve block. And this shows syringe stabilization with fulcrums for the buccal block. Okay. This is the landmark for the buccal block. So you'll see with this cotton tip applicator that they're just going straight back, straight back. It's going to be the most distal, straight back to the most distal mandibular molar. This is the needle insertion point, which is in the vestibule, distal and buccal to the most distal molar in the quadrant, and at the height of the occlusal plane. The depth penetration, like I said, it's only a few millimeters, 1 to 4 millimeters. And the deposit location is in the long buccal nerve as it passes over the anterior border of the ramus. The amount of anesthetic to deposit is approximately 0.3 to 1/8 or 1/4 of a cartridge, and the length of time is approximately 10 seconds to administer that. Now the complications would be leakage of the solution at the injection sites, and this is caused by the bevel of the needle only partially in the tissue. You would correct it by deeper penetration or reinsertion. Another thing that can happen is ballooning of the tissue, which is going to be caused by rapid deposition of the solution, and you correct that by slowing down the injection. And then another complication would be cheek biting, and you just correct that by educating the patient that they're going to be numb in that area and to be careful. You want to rinse the patient's mouth after the injection, all injections, but specifically or especially this one, because the anesthetic can leak, and you don't want to, it just doesn't taste very well, so you want to rinse out the patient's mouth. All right. We're next going to talk about some different blocks. So the mental block, we're going to talk about the incisive block and the Gaugates block, as well as the VA or the Vazirani-Akinosi mandibular block. So the mental block is going to be recommended for anesthesia of the facial gingival tissue, usually of the anterior teeth and the premolars, anterior to the mental foramen. It also anesthetizes the lower lip and the skin of the chin to the midline. The deposit location is where the mental nerve enters the mental foramen to merge with the incisive nerve to form the IA nerve. The location of the mental foramen is usually between the apices of the first and second mandibular premolars. So to locate the mental foramen for the mental block, you want to palpate intraorally the depth of the mucosal fold between the apices of the mandibular premolars, or you can look at the radiographs and it'll give you the site indicated on the radiographs. You can see the the general location of where it is on that patient, and then you feel for a depression surrounded by smoother bone that you can feel on the surface. So the mental foramen, keep in mind there could be variation. The mental foramen can be as far posterior as the mandibular first molar and as far anterior as the distal surface of the canine. But the deposit location is where the mental nerve, as I was mentioning before, mental nerve enters the mental foramen to merge with the incisive nerve. All right, here is that target area and distribution of the anesthesia here for the mental block. The landmarks are the mandibular premolars, mental foramen, and the mandibular mucobuccal fold. The needle insertion point is going to be the depth of the mucobuccal fold anterior to the mental foramen, and the deposit location is going to be between the apices of the mandibular premolars, or the location determined by those x-rays that you look at. You want to make sure, so know that there's going to be no bony contact made with the needle for the mental block. The amount of anesthetic that you use is approximately 0.6 milliliters, or 1/3 of a cartridge, and that should take you about 20 seconds to deposit. This is the operative position for the right-handed clinician for either the mental block or the incisive block. And there's two different approaches. So here they're showing the vertical approach, where the right-handed clinician is sat at 12 to 1 o'clock. The problem with the vertical approach is with the operator positioned for the vertical approach at 12 or 1 o'clock, the patient is more likely to see the syringe because it kind of comes over their face. And so if you are doing the vertical approach, you just want to ask the patient to close his or her eyes. Okay. This shows syringe stabilization for either the mental block or the incisive block. And then it shows the different approaches. So in this top left, this is the horizontal approach for the right side, where the syringe barrel is resting on the index finger of the non-dominant hand. The top right, this shows another horizontal approach, but for the left side, and the syringe barrel is resting on the index finger of the non-dominant hand. This is showing the vertical approach for both the right and left side. The syringe barrel is resting on the thumb of the non-dominant hand. So just keep in mind with this injection, there is a vertical approach and there is a horizontal approach. This is what the vertical approach looks like coming over the patient's eyes. This is what the horizontal approach looks like. This is the injection site for the mental block or the incisive block. On the left-hand side, we have the horizontal approach, and on the right-hand side, we have that vertical approach. Needle insertion for the mental block or the incisive block. The left-hand side here shows the horizontal approach. The right-hand side shows the vertical approach. Complications may be the hematoma, which is going to rarely occur, even though positive aspiration is the second most frequently used of all block injections. The technique adjustment would be to apply pressure with gauze to the area and reassure the patient. So I'm going to take this time to let you know the injection that has the highest rate of positive aspirations is the IA, then the mental block, then the PSA, in that order. Highest rate of positive aspiration, IA, then mental block, then PSA. The next block is the incisive block, which is going to be recommended for anesthesia of the teeth and the periodontium and the facial soft tissue anterior to the mental foramen, usually anterior teeth and premolars. It's useful when there's a crossover of the contralateral incisive nerve and there is still discomfort on the mandibular anterior teeth after giving that IA nerve block. It's also useful for non-surgical periodontal therapy for routine maintenance on sensitive anteriors. So you want to, what's the difference between the mental block and the incisive block? Do they both anesthetize the mandibular anterior teeth? No, only the incisive block anesthetizes the mandibular anterior teeth. Okay. here's the comparison. So the difference, the incisive block anesthetizes teeth. The needle length and gauge for both is going to be the 27 gauge short. The operator position is the same, the syringe stabilization is the same, the landmarks are the same. The needle insertion point, penetration, and location is the same. Amount of anesthetic is the same, and length of time to deposit is the same. So what's the difference between the mental block and the incisive block, other than the incisive block anesthetizes mandibular anterior teeth? The technique after the injection is different. So, the difference there with the technique after the injection is with the incisive block, you want to gently massage the area of the deposition, which is going to, massaging that area is going to push that local anesthetic agent into the mental foramen, and therefore it's going to anesthetize first the shallow mental nerve and then the deeper incisive nerve. And therefore, if anesthesia of the tissue innervated by the mental nerve, if it gets into that incisive nerve as well, the soft tissue anesthesia precedes pulpal anesthesia. So you just have to make sure you wait some time, massage that local anesthetic into that mental foramen, make sure that you receive anesthetic to that deeper incisive nerve so that the mandibular anterior teeth are anesthetized as well. This shows the dissection showing a probe deep at the injection site or needle insertion point for either the mental block or the incisive block. Number 1 here, that's going to be the mental foramen. Number 2 is the depressor muscle, and the depressor oris muscle. They're different muscles of the mouth. And then number 4 is going to be the mental nerve and the vessels. Number 5 is the lower chin, and number 6, that's the neck. Okay. The incisive block, this is the target area and distribution of the anesthesia for the incisive block. The technique difference, as I was mentioning before. Okay, so with the mental block, you do not want to massage the tissue after the mental block injection. You do want to apply gentle pressure or a soothing massage to the injection area for at least 2 minutes after the incisive injection. It's also helpful to position the patient upright or semi-upright position after the injection to help with diffusion of the anesthetic solution. The purpose of that gentle massage or the tissue after the incisive block is to force more local anesthetic agent into that mental foramen. The reason why you have to massage the local anesthetic agent into that mental foramen is, again, so that local anesthetic agent can get into the mental foramen. But the reason why you do not have to massage the local anesthetic agent into the mental foramen after the mental block is because the mental nerve is located closer to the tissue surface than the deeper incisive nerve. Anesthesia of the mental nerve and of the soft tissue is going to precede pulpal anesthesia of the incisive nerve. Okay. Some of the incisive block complications would be inadequate anesthesia. The causes would be inadequate volume of the anesthetic or inadequate duration of pressure over the mental foramen. The correction of that would be to re-inject in the correct location and apply firm pressure to the deposition site for a minimum of 2 minutes. Another complication would be a hematoma, so same percentage as for the mental block. Occurrence is still rare for a hematoma, but if it did happen, you want to apply pressure with gauze to the area and reassure the patient. The next block that we're going to talk about is the Gao-Gates mandibular block. It's recommended for extensive procedures during quadrant dentistry or with failure of an IA block. This is the true mandibular block, so then these are all the nerves that it anesthetizes. The reason why it's a true mandibular block is because it anesthetizes the entire mandibular nerve in most patients. This is the area that, this is the distribution of anesthesia for the Gaugates block, including that buccal periodontium and the gingival of the mandibular molars, whereas if you were giving an IA block, it wouldn't include that, and you would have to do a buccal block as well. So it anesthetizes the mandibular teeth to the midline, the periodontium, the buccal and lingual gingival of the anesthetized teeth, the lower lip to the midline, the anterior 2/3 of the tongue and the floor of the mouth, as well as the skin over the zygoma and the posterior part of the cheek and temporal regions. This is going to be the target area for the Gaugates block. The needle length and gauge is 25 gauge long, and the operator position for the right-handed clinician, they want to be at 8 o'clock, for the left-handed position at 4 o'clock, and the syringe stabilization, the syringe will rest on the patient's chin. The landmarks, extraoral landmarks, is going to be the lateral border of the tragus and labial commissure. Intraoral landmarks are the mesiolingual cusp of the maxillary second molar and soft tissue just distal to the maxillary second molar. This is the injection site for the Gaugates block. The needle insertion point, so the oral mucosa it's going to be the oral mucosa on the mesial of the mandibular ramus, just distal to the height of the mesiolingual cusp of the maxillary second molar. The depth of penetration is going to be approximately 25 millimeters, or 3/4 the depth of the long needle, until bone is contacted. The needle will naturally withdraw from the periosteum when the bony contact is made, so there's no need to withdraw further from that. The deposition location is going to be anterior-medial border of the mandibular condyle neck, just inferior to the insertion of the lateral pterygoid muscle. The amount of anesthetic is approximately 1 full cartridge. The length of deposition would be 60 to 90 seconds for that. The advantages to this block is that there's going to be a higher success rate than the IA nerve block, and the injection is going to last longer than the IA nerve block. The disadvantage is the anesthesia of the lower lip and the temporal area. So it's going to be contraindicated with patients with limited ability to open their mouth, and the different complications that may arise are hematoma, which you would just apply pressure with gauze to the area and reassure the patient. But keep in mind that this block has a less than 2% positive aspiration rate, so hematoma is rare. The next one is the Vazirani Akinosi, or VA mandibular block. The nerves anesthetized with the VA block include the IA, lingual, mental, incisive, and mylohyoid within the pterygomandibular space, as well as the long buccal nerve, approximately 75% of the time. This is a closed mouth mandibular block. It's useful when soft tissue structures persistently obstruct the view of the necessary intraoral landmarks used in the IA block. This allows clinically adequate anesthesia of the patient that has severe trismus and cannot open their mouth very wide. So this shows the target area or deposit location for the VA block. A shows the medial surface of the mandibular ramus within the pterygomandibular space, and B and C show adjacent to the maxillary tuberosity. Okay. This injection goes in straight like this, closed mouth block. The target area and deposit location is going to be center of the pterygomandibular space and approximately equidistant between the mandibular foramen and the neck of the mandibular condyle, as well as being adjacent to the maxillary tuberosity. The indications, of course, we mentioned before, procedures on patients with severe trismus, or when the IA block is less than clinically effective, or extensive quadric coverage is needed for procedures because it anesthetizes most of the mandibular nerve. So the nerves anesthetized is the IA nerve, lingual nerve, mental nerve, incisive nerve, and mylohyoid nerve. The needle length and gauge is going to be a 25 gauge long. It shows the clinician position for both right and left sides at 8 o'clock for the right-handed clinician, 4 o'clock for the left-handed clinician, resting the pinky of the non-dominant hand on the patient's chin. Okay. And this just shows the injection site for the VA block. Needle insertion for the VA block, the depth of insertion again is going to be 25 millimeters or 2/3 to 3/4 of a long needle without contacting bone, with the hub of the syringe ending up opposite the mesial aspect of the maxillary second molar. The amount of anesthetic is about a full cartridge, wanting to take about 60 to 90 seconds to deposit that full cartridge. All right, so the troubleshooting paradigm may be used to achieve clinical effectiveness. If the needle is placed too medially, it will end resting medial to the sphenomandibular ligament and only the superficial lingual nerve. If there is discomfort during the procedure, the VA block can be re-administered if there is still trismus present. Out of concern for the risks of complications for this block, the clinician may also inject the agent at too inferior a position, similar to the IA block. Okay. So some of the complications would be motor nerve paralysis, decreased risk of a let's go back to the motor nerve paralysis. So because the motor nerve paralysis develops as quickly or quicker than the sensory anesthesia, the patient with trismus will begin to notice increased ability to open the jaws shortly after the deposition of the anesthetic. And there's decreased risk of positive aspiration as well as hematoma formation as compared to the IA block. The depth of needle must be considered with this injection. You don't want to go too deep. All right, the next one or few that we're going to talk about is the mandibular supplemental injections. They're the 3 supplemental injections that can be administered with the mandibular arch as well as the maxillary arch. So we talked about these maxillary arch already, but we're going to talk about them again. We have the mandibular supraperiosteal injection, the mandibular interseptal injection, and the mandibular periodontal ligament injection. All have a high level of clinical effectiveness and associated on the visual analog scale ranging from 0 to 6 with the correct technique by the clinician. The downfall is the administration of these injections is of short duration. One of the common uses of the supraperiosteal injection is when there's incomplete anesthesia of the mandibular central or lateral incisors following an IA mental or incisive block. This injection can be performed along the medial surface of the mandible as needed. And keep in mind that with this, everybody's root length of teeth may vary, so that's something to keep in mind. Table 13-14 in your book discusses mandibular teeth and average root lengths. This next figure is going to show mandibular supraperiosteal injection, the target area. This one here shows the target area and distribution for mandibular supraperiosteal injection. This shows the vertical approach and this shows the horizontal approach. The next one that we're going to talk about is the mandibular interseptal injection, which is used when there is a stronger need for hemostatic control of the interdental papilla of the attached gingiva. Injection can be used in either dental arch, and it's usually administered following the nerve block for the region that is being worked on to allow less discomfort, as well as having a low level of you just want more. If you want more hemostatic control, this is what you'd give interdentally. Typically, the mandibular posterior sextant is the focus for this injection within the mandibular arch. And for a more detailed discussion of this injection, you can refer back to the chapter 12. The next one is the PDL injection, or the periodontal ligament injection, and this is used when pulpal anesthesia and associated periodontium and gingiva is indicated on a single tooth, mainly within the mandibular arch. It's going to be less clinically effective within the mandibular arch and provides a short duration of pulpal anesthesia and anesthesia of the associated facial or lingual periodontium and gingiva. But there's going to be no collateral numbness of the tongue or the lower lip with this injection. So this is the example of the distribution of the distribution of the anesthesia for the PDL injection. Again, the indications would be procedures requiring pulpal anesthesia of the single tooth and anesthesia of the associated periodontium and gingiva of that single tooth or around the area. The nerves anesthetizes the trigeminal nerve endings at the apex of the selected tooth and into the marrow spaces of the alveolar bone. The needle length gauge is a 27 gauge extra short or 30 gauge extra short. The target area is that alveolar bone proper of the alveolar process. The depth of insertion is little, it's about 1 to 2 millimeters into the alveolar bone proper after bony contact, and the amount of anesthetic agent is about 2.2 milliliters or 1 stopper. Okay, it's going to take about 20 seconds to administer that. The advantages of the PDL injection is absence of lip or tongue anesthesia, single dose and minimal volume of anesthetic. This is a good alternative when other methods are ineffective, and there's minimal post-injection discomfort. Post-operative complications with these are very unlikely, and it's awesome injection because it minimizes the bleeding in a target area, and there's a decreased risk for toxicity. So again, this is utilized when pulpal anesthesia is indicated on a single tooth of the mandibular arch. This is particularly beneficial to children and special needs patients to decrease the risk of self-mutilation. Okay. Now the disadvantages is that the needle placement may be difficult and experience is necessary for this. Anesthetic may leak into the patient's mouth, causing a bitter taste. It's short duration of pulpal anesthesia, and it's contraindicated in areas with infection or severe inflammation. There's also excessive pressure needed for the injection, which may cause breakage of the glass cartridge in a standard syringe and may cause tissue damage. Now, I guess it's up to the clinician to decide if the advantages outweigh the disadvantages for that injection. To review, overall the mandible is more dense than the maxilla, so it makes the supraperiosteal injections of the mandible not as successful as in the maxilla. The supraperiosteal injections are more effective on the mandible of the anterior teeth and can be successfully administered for crossover innervations. Substantial variation in the anatomy landmarks in the mandibular bone and nerve is going to complicate the mandibular anesthesia. The IA block is the one that's recommended for anesthesia of the mandibular teeth and the associated periodontium, as well as the lingual soft tissue to the midline, plus facial soft tissue anterior to the mandibular first molar. Then you withdraw from the IA block and you reinsert for the buccal block, which is recommended for anesthesia for the buccal soft tissue of those mandibular molars that was not captured with the IA block. For half mouth treatment, you want to give injections in this order. So IA and buccal blocks first, the maxillary facial injections, and then the palatal injections. And you want to begin instrumentation on the maxillary arch and then proceed to the mandibular arch. The deposit location of the IA block is slightly superior to the entry point of the IA nerve as it moves inferiorly to enter into the mandibular foramen. During the IA block, we talked about what happens if bone is contacted too soon or if bone is not contacted at all, and how you need to reposition that syringe. That's important. You got to make sure you understand that and you know what to do if you find yourself in that position, which happens a lot. following the IA block, failure of anesthesia of the mandibular first molar could be a result of the innervation of the mylohyoid nerve, and incomplete anesthesia could mean that there's a presence of a bifid inferior alveolar nerve. Also, something to keep in mind is that lingual shock may happen as the needle passes by the lingual nerve during the IA block. So what should the clinician do if the mandibular first molar is not anesthetized by the IA block? Well, the clinician can provide infiltration anesthesia on the lingual border of the mandible to anesthetize the mylohyoid nerve. Now, how can the clinician detect if there's presence of a bifid IA nerve? Remember, we can look at that radiographically. If there's a double mandibular canal, that could be noted. Also, the mandibular foramen, a second mandibular foramen may be located inferior to the first. That's something to keep in mind. Also want to know that the IA block has the highest positive aspiration rate of all block injections. And so you want to aspirate on 3 planes and re-aspirate every 1/4 cartridge. Paresthesia may occur following the IA block, and bilateral incisive mental blocks may be useful for sextant canine to canine treatment. Paresthesia may happen with the IA block, which is going to be trauma to the lingual nerve, spread of dental infection from a contaminated needle. Overall, what causes paresthesia, or the most common cause of paresthesia, is problematic surgical extraction of impacted molars. The mental block is recommended for anesthesia of the facial gingival tissue, usually of the anterior teeth and premolars, anterior to the mental foramen. It also anesthetizes the lower lip and the skin of the chin to the midline. The incisive block is recommended for anesthesia of the teeth and the periodontium of the facial soft tissue, anterior to the mental foramen, usually the anterior teeth and premolars. Keep in mind that the difference between these, with the incisive block, you have to gently massage the local anesthetic into that mental foramen. The Gaugate's mandibular block is recommended for extensive procedures during quadrant dentistry or with failure of the IA block, and the Vazirani-Akinosi mandibular block is recommended when a similar region of anesthesia is needed as the IA block, but with a closed mouth situation, or when there is difficulty administering the IA block. Supraperiosteal injection is recommended when pulpal anesthesia is needed on a single tooth, or when anesthesia of the associated periodontium is needed in a localized area. An intraseptal injection is an intraosseous supplemental injection recommended when there is a need for additional hemostatic control. The PDL injection is the intraosseous supplemental injection recommended when pulpal anesthesia and the associated periodontium and gingiva is indicated on a single tooth. That includes mandibular anesthesia. Let me know if you guys have any questions.